We're talking about in more modern oncology drug development. I'm going to focus on a couple of different problems today, and address these problems within the context of a completed clinical trial. As we discussed on the first slide, right, the traditional paradigm has ordered dose levels with respect to the probability of DLT and efficacy. In a more contemporary setting, we might have orderings of probabilities of DLTs that may be unknown but among some of the dose levels, and that can happen when we have drug combinations in which we're escalating more than one agent. So I'm not talking about fixing the dose level of one agent and then just escalating one agent, but if I'm escalating more than one agent, I'm operating in two dimensions, as we'll see, and we'll have some uncertainty that we don't have in the simple case. And then we have a single binary DLT endpoint that drives the dose allocation and the MTD recommendation. We're going to talk about multiple endpoints. What if the primary objective requires accounting for both toxicity and efficacy to determine an optimal dose? So we're going to start with the drug combination setting. So here's the challenge with drug combinations. Escalation with more than one agent. If we were to start the trial here, this schematic has 3 dose levels of 2 agents, resulting in 9 drug combinations. So already you can see a problem in which the dimension is much larger. 9 dose levels versus 4 means I'm going to need more sample size. Probably I'm going to have to take more into account in terms of how do I, especially if the MTD were to be at that upper corner, how do I get there in a efficient fashion? But the main problem here is if I start at the lowest dose level of each agent, dose level 1 of each agent, I'm at the green dot. If I deem that to be safe, according to the number of DLTs that are observed, where do I go next? Do I go to red or do I go to blue? I have some uncertainty about which one is more toxic, right? So again, we can conversations with clinicians can guide us in a certain direction if they have some inclination that or desire to move in a certain direction with some rationale, not just that they want to do that, with some rationale. But in general, we are raising the dose level of one agent and lowering it for the other agent when we talk about the relationship between red and blue. So we have some uncertainty about which one is more toxic and which one has a higher probability of DLT. So what's typically done in practice in this area is to choose a path with a known ordering among that grid and apply some single agent method. So this is a somewhat old review, but in Annals of Oncology, Riviere et al. Did a review of drug combination studies in which more than one agent was being explored in terms of its dose escalation. 99% did this. They chose some path along this grid and applied some method that would work for single agent evaluation. So what's happening here, right? We're missing out on any gray combination, right? You're never going to find that as some optimal dose. You're really restricting your attention to what you can find in this case. Okay, so we're going to come back to this, but that's a little bit about the challenge of drug combination dose finding. The other problem we're talking about is multiple endpoints, toxicity and efficacy. Should we be targeting the MTD, right? So should we be pushing that dose higher based on a single toxicity endpoint, or is there some other dose that might be more optimal in terms of both its safety and its efficacy? And this is a big call from lots of different entities, FDA, oncologists, patient advocates, lots of different folks calling for the end of this more is better approach to dose finding in cancer. And this was a Cancer Letter article from last year that's discussing that. And also from the FDA, there's this Project Optimus, which is an initiative to reform how dose optimization and dose selection is done in oncology. And they're asking for designs that account for both toxicity and efficacy. And we're going to talk about a couple of different ways to do that today in the rest of the talk. But this sort of, these initiatives are driven by this revisiting of our assumptions from the first slide. So on the left panel is our original slide, the second slide that we looked at with the increasing toxicity and efficacy, the MTD giving us the most promising outlook for efficacy, again, operating in a chemotherapy era. And then in targeted therapies, and this could apply to other types of therapies, cell therapies or immunotherapies, we have this increasing toxicity assumption. And you can see where the MTD is, again, bumping up against that target rate. But the efficacy curve now somewhat plateaus at a lower dose level. And there's a lower dose from the MTD that's just as nearly efficacious as the MTD, but has lower toxicity, right? So beyond the arrow there under the green text, I'm just merely adding toxicity and not adding much efficacy, right? So maybe I want to find a lower dose that gives me a more promising outlook for, or nearly as promising outlook for efficacy, but lowers my toxicity. Okay, so this isn't as easy as perhaps it sounds, because there's some complications with the or considerations that need to be taken into account with the efficacy endpoint. So what efficacy endpoint is going to be used, right? So if we're talking about a DLT endpoint that's captured in a shorter period of time, like a cycle of treatment, efficacy is usually scored after more time than one cycle of treatment. So we might have this delayed effect, like we discussed earlier with the toxicity. We might have an endpoint that's observed well after the patient starts treatment. So now, if we're making adaptive dose assignments and we have this lag to wait for the efficacy endpoint, right? Where do we assign patients that are coming on to study while we're waiting for endpoints to be observed? Okay, so this is a very general complication in the sense that with efficacy it could happen, but it could also happen with late toxicities, as we discussed. So we have these complications that prevent us from just saying, oh, I got my efficacy endpoint, I got my toxicity endpoint, let's make a dose assignment, right? These are practical complications that throw a wrinkle into what we hope and want to do. So some other important design questions in this context are: do we have a homogeneous patient population? Somewhat. Are there validated early surrogate biomarkers for efficacy that are available? So if I use some shorter term endpoint, like some biomarker, is it predictive of longer term clinical efficacy, right? This is right, we could use something, we're hitting some target inhibition, looks great, but is that reflective of long-term benefit from the drug? And we discussed, when is efficacy scored relative to toxicity? So is there a long lag time between the endpoints? And also, not sort of embedded in the slide, if you will, is that the accrual rate matters, right? How often are patients coming on to study? That's what we mean when we say, how long does it take to score efficacy? If it takes a long time to score efficacy, no problem if the patients are coming in slowly, but you're going to have a long trial, right? So the accrual rate makes a difference here. So one approach to this is gaining some traction, is having a more sequential approach to this. This is not an approach I'm going to spend a lot of time on in this talk, but I'm just going to make you aware of it, in which we now conduct a dose escalation study, but we're choosing multiple doses to carry forward to compare efficacy endpoints on. So it might be a dose ranging study in which we have these 4 dose levels, and we're going to put patients on as we normally would in a dose escalation study, but then at the end I'm going to select more than one to carry forward, then have some randomized dose optimization in an expansion cohort or an early phase 2 setting in which I'm comparing more than one dose level. And comparing there means I'm going to still evaluate safety, but also I'm comparing their efficacy. Now I don't have as many problems with the adaptive dose assignments and patients, the accrual rate versus the time it takes to score the efficacy. So we've sort of whittled down the problem to just 2 dose levels, and we're able to focus a little bit more. So this is one approach to this type of problem, which is a sequential dose escalation, then dose optimization, but the dose escalation is finding a range of doses. And that could happen with any type of design, CRM, or we could talk about some other designs, but you could use a variety of designs in the dose escalation to decide on a dose. So I think that what's needed here that you don't have in the classic phase 1 setting is, in the classic phase 1 setting, you're trying to get to one of those dose levels based on the DLT rate and sort of set up camp and put as many patients as you can at that dose level. And that's the characteristic of a CRM. It's like that curve that's moving up and down. That's trying to get to a spot and sort of set up camp there and get as many patients. These are small studies, right? 20 patients, 30 patients. I'm trying to get as many as I can at that MTD, right? So here, if I'm going to take more than one forward, I need more than 1 or 2 patients to take it forward on a dose level, right? I'm going to need some more information. So there's been some work done on obtaining data at multiple dose levels, both in terms of randomizing patients. We saw that on the previous slide with respect to after you select the dose range, randomizing patients to doses, but also in what's called controlled backfill. So if I'm at a certain point in the dose finding process in which I've arrived at dose level 3, I could, and I'm waiting for DLT outcomes at that dose level 3, and patients come in the door ready to be put on trial, can put them at a lower dose level, not ad hocly, with some good rationale. I can put them at lower dose levels to obtain some more information if we know those doses are safe. So this is what this looks like. So the first cohort is just a cohort of 3 patients. And they're in the dose findings phase. They don't have any DLT, so we move up to the second dose level in the second cohort, second dose level, and we backfill to the first dose level, 3 more patients. So you can see as we move up the dose levels in the dose finding, we're also allocating patients to lower dose levels to obtain more information, and we can do that in somewhat of a randomized fashion. We could say 1 to dose level 1, 2 to dose level 2. There's a formal mechanisms for doing this in this paper here. So that's the idea. Let's get some information at lower dose levels that we need. Okay, so this sort of sequential approach has some recent methodology. This has appeared in Biometrics by Drs. Guo and Yuan. And this is a dose ranging approach to optimizing dose in oncology drug development. This has a CRM flavor in the dose escalation, focusing on a therapeutic dose range after that, then randomizing patients to those doses based on efficacy. So this is a very nice paper that just came out this year. Okay, so that's sort of the sequential approach. Let's dose escalate, focus in on a small range of dose levels. Now we're going to talk about a more concurrent or simultaneous approach in which we're using the toxicity and efficacy data when we have it to make dose assignments based on both of those endpoints. So this has a flow that is to treat the first cohort of patients at some pre-specified starting dose, collect both efficacy and toxicity data, fit dose efficacy and dose toxicity models, and then go through are all doses deemed to be ineffective, then we would stop. If they're all deemed to be too toxic, then we would stop, but otherwise give the one that's optimizing some dose desirability criteria. And we don't have enough time in the day to talk about all the different types of dose desirability criteria that have been proposed in the literature. People have these different trade-off functions between toxicity and efficacy, some of which I've worked with, so we can talk about the way that I did it in the trial that follows, but there's multiple ways that could happen. I want to trade off toxicity for efficacy, and there's, of course, multiple functions that could be proposed for that. So we're going to talk about this type of approach with an early phase trial of two agents that completed accrual in 2019. The paper was published in 2022. This is a dose-finding study of ibrutinib plus venetoclax in relapsed refractory mantle cell lymphoma. There's the clinical trial identifier if you're interested in that. And this was a multi-institutional trial between the University of Virginia, Washington University, and St. Louis City of Hope and Emory. 35 participants were accrued between 2015 and 2019, and used some methodology, basically a continual reassessment method extension for both toxicity and efficacy to be used in drug combinations that was published in 2014. So here's our structure here. We have this 2 dose levels of venetoclax, 3 dose levels of ibrutinib. I want to find some optimal dose among these drug combinations. And of course, we're going to have the problem that we looked at in the drug combination intro, in which along these diagonals, I'm going to have some unknown relationships between toxicity probabilities and efficacy probabilities. Okay. So here's how, this is part of the process for me, and one that I somewhat enjoy, right? Let's talk about what you want to do. Let's talk about what you have in mind and what question you're trying to answer. And so this is sort of a summary of our initial discussions with the clinical team. They initially brought us a schema that excluded these two drug combinations at the bottom here, and they wanted to go to the way of doing things like we looked at in the drug combination, what's done in practice slide, right? Let's start at this lowest dose. If that looks safe, move up here, and then just move along this ordered set of dose levels and find an MTD. And so they initially asked about what's called the 3+3 design. I did not go over that in this talk, but it's a very simple rule-based method for conducting dose escalation. But they said they were open to other designs. I've given this talk before, some portion of this talk before, in which I had a little asterisk here. I didn't put it on this one. And the asterisk said they were open to other designs after we told them that we don't do the 3+3. So they were as open as they could be to statisticians who would not engage in the 3+3. So the statistical team sort of tried to focus on, my colleague and I tried to focus on, let's not do this, right? Let's consider all combinations if you're really interested in what's the optimal combination among this grid of 6. And let's use both safety and efficacy to target lower combinations. So we had conversations about, is there a relevant efficacy endpoint to use that's observable in a short period of time? Could we use that to target lower doses? Because what I've provided for you here is that the 400 milligrams per day is MAD, means maximum administered dose in monotherapy trials. So in the monotherapy trial of venetoclax, the maximum administered dose was pushed up to 400 milligrams a day. And in the Brutinib monotherapy trials, the dose was pushed up to 560 milligrams a day. And they're bringing us doses that are lower than that. So they're already inherently saying we want to back off what was maximum administered in monotherapy when we combine these drugs, right? So we're backing off those MADs to try to find something lower that provides just as much efficacy, but perhaps lowers the toxicity from a state that would give the maximum of each of the two drugs. So, and if we need to get up there, we can, right? But that's not where we want to focus our attention if possible. Okay, so here's a little bit more about the trial, especially as it relates to endpoints and objectives. Our objective here was to identify an optimal dose combination defined by high response or efficacy, high response rate, and an acceptable level of toxicity, and that was defined with a less than or equal to 25% DLT rate. DLT window was a 6-week assessment period, and the response was a CR or a PR. That's complete response or partial response based on tumor shrinkage at 2 months from the start of treatment. So I got a 2-month endpoint, and this should put a little caveat next to this expected accrual. Expected accrual rate, 1 patient per month, is what the clinicians expected it to be. In my experience, it's always slower than in the places I've worked. It is slower than the clinicians think that it is. So we did not expect this to be the case. You'll see the actual, I have for you the data, so you can see the actual dates. And it doesn't come at such a fixed intervals, right? Maybe 2 come in a month, and then we wait 4 months for the next one. So as I'll get to it towards the end, we did not account for what if I have pending data, and well, we accounted for that in a specific way. We didn't use models that sort of account for the fact that I'm still waiting for the outcomes for some patients to be able to make dose assignments for future patients. Here's the safety assumptions. We got to think back to sort of the drug combination slide, in which the probability of DLT increases with each dose of the agent when the other agent is fixed. So basically, toxicity increases, probability of DLT increases as I go up a column or across a row, right? But along the diagonals, I have some uncertainty. So A is the least toxic combination. F is the most toxic combination. Ordering between diagonal elements is unknown. So I have some uncertainty among the DLT probabilities along diagonals. This formulates a set of possible orderings, right? We can use this information like, is B less than C or is C less than B, right? Or is E less than D or is D less than E? We don't know. Let's formulate some possible orderings that could be used to model DLT probabilities. So again, A is the lowest, right? F is the highest, and then I have the uncertainty among the diagonal elements. And so in some of these, B is less than C, and others, C is less than B, D is less than E, and E is less than D, right? And we have some various possibilities here. So this formulates like, okay, remember back to that first CRM slide, we have the simple model. It's just going to update the curve, right? I can do that among these different orderings and then do some model selection adaptively. So that's going to form the basic idea for this, okay? All right, so again, I could go through a whole talk perhaps, or at least half of one on how to choose these values. Happy to answer any questions on that. But again, we have this simple power model, right? These prior guesses or pre-specified constants for probabilities of DLT that reflect those orderings, right? So in the first one, B is less than C, right? In the second one, C is less than B, right? And I'm representing that through those skeleton values or those pre-specified constant values. And I'm just raising those to a power. It's just I have M of those now, I have 5 in this case, right? Okay, so M is going to index the ordering, and I have a sort of a skeleton representation under each of the orderings. I'm going to take this idea, I'm going to do something similar for efficacy, but I got a little bit more to consider here, okay? So for efficacy, we talked about we could have this plateau relationship, right? So I operate under a couple of different assumptions here. The probability of response is increasing with dose of one agent when the other agent's fixed. So I increase efficacy as I go up rows and across columns, same deal. Or it reaches some plateau at an intermediate dose pair. So it's going to reach C, and then everything above C is going to be the same, right? Or reach B here, and everything, you know, E, F, D is going to be the same. I'm going to have this plateau surface, right? So it could be perhaps I have something like this. A is less than B is less than C is less than D, and then D equal F, E equal F, right? And I have this plateau. So I can account for these different types of possibilities in skeleton specification, okay? So that's what we did. So under the increasing assumption, right, I have a different representation of that power model to represent that I'm talking about efficacy here, but basically the same model. And these pre-specified constants under each of those ordering assumptions. And again, there's algorithms for selecting skeleton values. And then I have that same sort of idea with plateau assumptions, right? So I have it plateaus at that first diagonal, plateaus at the second diagonal, plateaus at the second column, plateaus at the third column, plateaus from the beginning, right? So I have these different possibilities. So now I have more orderings, I have 10, right? And I'm going to use this information adaptively. Again, fit the curve. I'm going to have 10 of them, do some model selection, which one's most consistent with the data. That's the general idea. Okay, so so based on the DLT data, I'm going to estimate theta M, which is my parameter in the toxicity model. And for efficacy, I'm going to estimate beta based on these similar likelihoods, where the NIs are the number of patients that have been evaluated for toxicity at dose level I, or drug combination I, dose pair I, and YI is the number of DLTs that I've seen at that drug combination pair. And then ZI is the number of responses I've seen at dose pair I, and TI is the number of patients that have been evaluated for efficacy at that particular dose pair. Okay, so I have these two likelihoods. I'm operating with them independently, and again, we could talk about that as well, like models that jointly model toxicity and efficacy. That's definitely a thing. Like the literature is filled with methods like that. That introduces extra parameters, and we don't have a lot of data at various dose levels. So we're operating under an underparameterized model framework because we don't have a lot of data at any particular dose level. We're probably getting more here in this type of setting where we're backfilling patients to lower dose levels. But in general, in dose finding, we have one dose with quite a few of my sample size on it, and then the others have very sparse data. So the fitting of multiple parameter models is difficult in this setting. So I have these models that with these likelihoods, and or the parameters with these likelihoods, and I'm going to choose two orderings that maximize the value of that likelihood evaluated at its MLE. We could talk about Bayesian approaches to this. I've definitely done some work in that area. Posterior model probabilities, you can get more elegant here if you if you so desire. But the basic idea, those perform very similarly, by the way. If I'm doing this in a Bayesian context or a frequentist context, I'm not getting that much out of either one of those approaches over the other. So we sequentially choose the ordering, right? Maybe ordering one looks the best for both endpoints after 3 patients, and then it switches to another one after 4 or 5 patients. I'm using the data to tell me which ordering is most consistent with that data. And then I'm selecting the model under that chosen ordering and updating the estimates for the probabilities of each outcome. Okay. Now I'm going to use those probabilities to make some decisions. Okay. So let's talk about, again, we wouldn't have this slide perhaps with the Bayesian context to just model out of the gate and allocate patients, but in the frequentist framework, we need to have heterogeneity in the responses. I need a DLT and a non-DLT. I need a response and a non-response to be able to model. So this trial opened at UVA first before opening at other sites. First 3 participants went on study at UVA. Stage 1 of escalation, the reason I'm showing you this is sort of the randomization component. Like we talked about backfill and randomization. These are ways to get more information at other dose levels. And here, patient 1 is going to start on arm A in zone 1. We sort of zoned these to have sort of a framework or a structure on randomizing within a diagonal. So basically the zones or diagonals. Patient 1 starts on arm A. In zone 1, if no DLT, we randomize to B or C for zone 2. So the second patient is randomized to B or C if there's no DLT on A. Patient 3 receives the zone 2 arm that was not assigned to patient 2. So we fill that other one, right? Then when we get to the next one, like E and D, again, first one's randomized, then the other one's put on the other combination. And we continue this until we have a DLT or all arms have been tried. If all arms have been tried, you'll see that, and without safety issues, you'll see that we're adaptively updating a set of safe combinations to operate within. And if we've reached the top, everything's deemed to be safe at that point until we start running into safety problems, if any. So this is sort of how the trial got started. And then we had a model or a second stage that models the probabilities once we hit a DLT or obtained heterogeneity in the responses for both endpoints. So this is the actual assignments for stage 1. The reason I'm showing you this is just to show you what happened, but also you can sort of look at dates for when things were when things happened. So we started this 9/9/15. No randomization for that first one. It's just assigned to A, no DLT, and had a CR at 2 months, or a PR at 2 months. So we had a response. The second patient didn't come on until January of 16. So we had a 4-month period in which we didn't have a patient, right? Then things happened a little bit quicker, right? I'm okay with this February right after this January because I'm randomizing to that other arm in the zone. So I really don't need patient 2's outcome unless it's a quick DLT to assign the third patient. So I'm okay with the quick accrual there. And then what happens? We go all the way to May and June before we get the next patients. But again, I'm okay with the close May and June because I can randomize to D or E there. And then here we had 2 in July that we had assigned to E and D because we didn't have this data yet. So we just stayed at the same dose level for one more patient, for another set of 2 patients. And then this patient 5 had a DLT on 7/15, which is after this patient had already been assigned and was receiving treatment. So at that point, stage 2 begins with the modeling after 7 patients, but I'm using only the first 5 patients' data to make that, to do that modeling, right? So we're going through these periods where we're using less data than the full set to make to do our modeling and make dose allocations. Okay, so the assignment algorithm in stage 2, you saw how the modeling's done. We're going to adaptively update a set of acceptable or safe set of arms. So which arms, based on my estimated DLT probabilities, have estimated probabilities less than 25%, right? That was my unacceptable rate. And I'm going to form a set with that, right? I'm going to have this set of combinations that satisfy the safety criteria. And we used, based on the DLT data and the selected ordering according to the model selection process, we built a confidence interval using CRM confidence intervals, which, if you're interested, is in this paper here in 2003, computed for each arm. This is this confidence interval estimation is available in our package called Dose Finding for CRM. If the lower bound of the interval exceeded 25%, we eliminated that arm from consideration for the next assignment. If it's deemed too toxic, not considered. Okay. If A is ever excluded for safety, we stop the study for safety. Okay. So within that acceptable set, now now we have the DLT probabilities telling me what's safe. Within that acceptable set, I'm going to first do some randomization, and then for the latter part of the trial, just sort of hone in on one that maximizes efficacy. And again, in practice, this is not the end all be all of the amount of randomization that you have. You can randomize for half and then do the other half. You can randomize for the whole thing. I found that the operating characteristics are better when I had a small amount of randomization, and then I honed in on one that I'm maximizing efficacy for, or really I'm maximizing this probability of success. So we're estimating what this probability of success is. That's the efficacy estimate times 1 minus the probability of DLT. So there's my efficacy estimate times 1 minus the probability of estimate for DLT. So basically what that does is two combinations have the same efficacy. You're penalizing what their toxicity, using their toxicity probability to penalize the success of that dose. So the one that has lower toxicity would be chosen out of those two if you had two with equal efficacy. So this success, instead of just maximizing efficacy because I could have two ties, I maximize the success rate so that I have a little bit of a penalty of toxicity. Again, this is not the only function that could be used for this sort of trade-off. There's many that could be used. So we randomize to patients proportional to their estimates for the probability of success. And then for the latter part of the trial, I assign to the one with the highest estimated probability of success. Okay, so this was, again, just a snapshot of the data at a certain point, right? To make this dose assignment for modeling, we are using this set of DLT data, this set of efficacy data. We do not have data yet for this participant on arm C, because they were just put on study right before this one needed an assignment. So again, this is just illustrating at certain points, we're using less data than the number of patients that we have because we're still waiting on. Again, given the accrual rate, I wouldn't want this to be, I'm making an assignment for dose level 15 based on patients, the first 8 patients. I wouldn't want this gap to get too big. But given how the accrual was going, it wasn't going to be that big unless we just got an unexpected flood of patients, which probably would have paused accrual at that point. We never made a decision with more than a couple of patients pending for one of the endpoints. So this is an illustration for the second stage, just real quickly. So at some point, I think at the point that I made this assignment here, I have, or maybe it was one before this, I had DLT probability estimates that all look safe, right? This is higher than 25%, but the confidence interval lower bound was not, obviously. So A through F are deemed safe. Model-based estimates for response probabilities, I think I made this at a different point than this because maybe up here using all of the efficacy data as responses led this to be every dose is the same in terms of efficacy. So the success probabilities are just the blues times 1 minus the green, and I get these success probabilities in orange, and then randomly assign one to arm B in this case. We're going to stop the trial if the recommendation was to assign the next participant to a combination that already had 10 participants, or the maximum sample size of N equal 28. I know on the first slide you saw that we had 35 patients on this trial. We had to stop in the middle and make an amendment for like the one of the doses, the venetoclax on the y-axis, right? The rows of the drug combination matrix had a ramp up period. They would give, like, week 0 was 100 milligrams, then they would reach their 200 or 400. So they wanted to lower that ramp up from 100 to 50, and so it didn't have anything to do with the trial, but we had to pause and then sort of restart. And then we implemented these stopping rules again. So again, I could come back and give a whole talk on how did we use the data from the first portion of the trial to seamlessly keep the trial going. And that was an interesting part of this as well. But that's why there's a difference in the sample size. I didn't put too much information on the pause and accrual, just because I didn't think that was as interesting. But okay, so we had N equal 28 total patients. Final recommendation, either after 10 is treated at a dose or I've reached 28 is considered my optimal dose combination. Okay, so a few more slides here, we'll wrap up. So this is just a snapshot of simulation results for how this behaves. Again, we put a lot more in the protocol that showed this. So in this sort of ideal situation in which everything's safe and this upper combination has a really high response rate at 2 months, you see we're able to find that dose 67% of the time with an average sample size of 19.1 patients. And in this one, we had a plateau situation indicated by the green, right? Optimal dose is this one here with 25% rate and a 50% response rate. Everything above it is 50% response rate, but with higher toxicity. So we want to find this only 40%, but still not too bad in terms of this is the behavior of dose finding operating characteristics with 18.2 patients on average. And we also gave review entities like percentiles for the sample sizes, the percentage that stopped early, the overall percentage of DLT and responses under those two scenarios. And again, we did many more scenarios that showed this, but I just decided to highlight two there. So this is the final data for the study. No patient was put on combination F. Combination B was found to be our optimal combination. It had 6 patients before that pause, 10 patients after the pause. Overall response rate at 2 months was 15 out of 16. DLT rate was 1 out of 16. So at these upper ones, again, we had a good 3 out of 4 response rate here, 2 out of 4 here, 2 out of 5 DLTs at that one. So we needed to be lower than this. This one, the non-responder here was a stable disease, which means their tumor just didn't change enough to be progressive or a responder. These 2 misses were a progressive disease. So I think we actually ended up in a good spot here with a pretty high overall response rate at 2 months and only 1 DLT out of 16. So I show this to show we wanted to find a lower combination with less toxicity and just as much efficacy. And I think that we did that. And I think this was successful in that regard. So if you're interested in every dose assignment, if you're interested in this, you can see this is supplemental table in the clinical trial report, which appeared in Blood Advances in 2022. You can see every assignment and what data was used to make that assignment, right? I think transparency is important. And so you can see every dose assignment if you're interested in the supplemental material of that paper. So just a few concluding remarks about the study itself, and then I have a few more slides on sort of some new methodology I've been working on, just to touch on that real quick. So ultimately, as we discussed, we identified one of the lower combinations, a low DLT rate, a high response rate, better than the dose escalation based only on safety. We probably would have pushed up to one of those higher ones. As was just pointed out, we wouldn't have tried the dose that we ultimately landed on. All right, so some potential limitations. Could we have considered more response working models to account for different relationships? We did, as we discussed, we did not incorporate pending outcomes. Not sure how much that would have helped, but potentially it could have. Did not account for additional data in the final dose recommendation. So what I mean by that is the final dose was selected as the one that met our criteria that we defined in the objective, but the patients were evaluated for response after 4 months and then after 6 months, or after. This was a 2-cycle efficacy endpoint. They were evaluated after 4 cycles, after 6 cycles. The 6-cycle CR data, the number of complete responses, was a little bit better on the arm C, but we didn't, in the other diagonal from where we landed, should that be the optimal dose? I sometimes push back. I know it's the title of my talk. I sometimes push back on the word dose optimization in this case, right? I found a better dose, but I might not have optimized because I didn't take into account longer term endpoints, right? So this is a word that's thrown around very ad hocly in this literature, but I'm not sure we're optimizing dose. I think we're finding a better one than just one based on safety. But I still like the word dose finding for this because that's still what I'm doing. And so should we have recommended multiple doses? Maybe we take B and C forward and do some randomization just with those two after the study. I think that these are all could have been perhaps considered. The last one would have been resulted obviously in an increased sample size. We need to get enough information on more than one dose level. If you're interested in this work, there's the methodology that was used. There's the final paper. As I mentioned, you can see the supplemental has the full trial output. Okay, so one more thing I want to discuss, just a couple of slides. Limitations of the methodology we just talked about, right, is sort of the specification of so many models, right? If the dimension grows, I have to specify a lot, right? And this is another trial that I worked on in an LOI form, but never got off the ground, but it had 4 dose levels of one agent, 5 dose levels of the other agent. If I'm going to account for every uncertainty along these diagonals, I'm going to have a lot of models to specify to do what I just did, right? So number of working models increases, obviously, as the dimension and complexity of the problem grows. And it's just difficult to specify orderings and skeletons for a large dimension, and it results in a lack of robustness. So we have what's called, this is recent methodology, we have what's called a local continual reassessment method. And this restricts model and interim decision-making within a local dose set around where I currently am. So I'm only considering neighbors of where I currently am. I'm not modeling the whole surface adaptively every time. I'm saying, where am I? I want to move to a neighbor. Which neighbor should I move to? So same idea, specify orderings and working models, but now I'm in a much more confined space. And so suppose the current dose is 0.75, 122. This is my current dose level. I really would only consider these lightly shaded orange ones or the current one again, right? So I have 5 combinations to work within. And we restricted this even from these other diagonal neighbors, right? Let's just move to up or down in one direction, or up or down in one direction to the neighbor, or stay at the current dose level. And this is was just published in Statistical Methods in Medical Research this year, and done under an R01 I'm currently the PI for. So please take a look at this if you're more interested in sort of adaptations to this methodology that could be used in larger dimensional problems. Gone a few minutes over, but that's all I have. I really appreciate you listening. Thank you.